And so we'll start out today, we're going to be talking about biliary emergencies. And so my aim today is to talk about biliary emergencies and kind of delineate them from biliary emergencies to urgencies, and then even address situations where we can do some of these procedures a little bit more electively. And what that means. And so we'll kind of start off with the review of anatomy, and then of course go through all the disease symptoms with stone disease, such as cholecystitis, cholangitis, gallstone pancreatitis briefly, and then briefly touch on the things that we might have caused, such as biliary leaks and as well as perforations. And so here is one of my favorite pictures. We have the biliary system here that kind of this is the biliary system, and so we all start from the intrahepatics. We generally divide the intrahepatics into left and right, according to the patient, and then they combine into the common hepatic duct, and then they join the cystic duct that's coming from the gallbladder, and then it becomes the common bile duct, or the CBD. And so really all the way at the end of the CBD, we have the conjunction or the junction of the pancreatic duct. Now most times they're two separate ducts, but they really empty at the ampulla or the papilla, and that can cause some issues as well. There are times, like Dr. Eagle mentioned, that pancreatic duct can move up, but most times it kind of joins at that papilla. And so we'll review some of the terminology. When we talk about stone disease, we're talking about cholelithiasis, or the stones within the gallbladder. And these are very, very common. Now, you can have a lot of times where these stones do not cause any symptoms. They can cause biliary colic or, right upper quadrant abdominal pain, and that's when it becomes uncomplicated cholelithiasis. And then we can cause some issues with cholecystitis, cholangitis, and then gallstone pancreatitis. Now, the real big definition here, or the big change, is choledocholithiasis is when any one of these stones are found within the common bile duct, and they have their own issues. Now, most times the stones in the common bile duct will be secondary to stones from the gallbladder, and this is about 90% of the stones that we find in the common bile duct, usually. And so this is kind of going to play into the recommendations of getting a cholecystectomy within the same admission when a person is seen with choledocholithiasis. And then there are other issues as far as like Maritzi syndrome, when this stone can be stuck at that cystic duct and eventually cause some obstructive features within the common bile duct, or in the common hepatic duct, excuse me. And then here again is that redrawn image. Again, most times these patients are asymptomatic, but they can present with cholecystitis in 10% of patients. And then even more rarely is we present with patients with cholangitis, or stones within that common bile duct, or even gallstone pancreatitis in about 55% of all stone comers. And so these are very, very great images of, on your left side, we have an MRCP, and so this is an MRI that specifically looks at the bile ducts. And really kind of the same thing as right hepatic duct and left hepatic duct combined to the common hepatic duct and then meet up with the cystic duct. Now there's a little strand that kind of shoots off to the right of the screen, and that's the pancreatic duct. And then on the right side, we have a fluoroscopic image when we shoot down a side viewing endoscope, and then we shoot up a wire, and then you kind of inject it with dye, and then it lights up to become a cholangiogram and as well as a pancreatogram. Now, this is probably a bad day because we don't technically like to get into the pancreas or the pancreatic duct, but this is just kind of that example image as we move forward. And so biliary stones, I'm sure many of you are very, very familiar with it. There are certain risk factors, including age, especially greater than 55. Females are a lot more common, especially during pregnancy. And then we also have certain ethnicities that are more at risk, such as Native Americans, Hispanics, and then eventually Caucasians. OCPs are notorious, as well as obesity and hyperlipidemia. Now, we see this very, very frequently when patients come in with rapid weight loss from whatever reason, whether it be the new GLP-1s or even after getting gastric bypass, as well as terminal ileal disease resection in IBD patients. And a lot of times this is kind of a dysfunction in the bile salts, but these patients tend to have more formation of stones and eventually stone disease. And so we start off with the very basic of all biliary disease, and this is biliary colic, and this is that typical constant pain that ramps up for 30 minutes to an hour and then can last less than 6 hours and dissipates. This is not changed with position. You cannot burp this out. You cannot, kind of press on this. This is not reproducible palpation, and this can awaken patients from sleep. Now, this is very important to understand because as we move into symptoms of cholecystitis, this biliary colic can last greater than 6 hours, and of course, it can present with fever, nausea, vomiting, fever, nausea, and vomiting. Whereas jaundice is a little unusual because jaundice is essentially the buildup of bilirubin. And it's typically unusual in the setting of no clear obstruction. Now, it's always important to understand that elderly patients, immunosuppressed patients, don't typically present with the typical symptoms, and they can absolutely be asymptomatic. Now, we all start with a right upper quadrant ultrasound. This is a great test for cholecystitis because the sensitivity is fairly high at 84%, with the specificity at 99%. And really what we're looking for is three different things. We're looking for gallbladder wall thickening. Typically, it's in the 4 millimeter range or greater than 2 millimeters. You can sometimes see intraluminal gas, and then you can also see inflammation or the pericolous cystic fluid. And on the right, you have we have a CT imaging with clearly that. Don't look at the top right part of the liver. That's definitely something else. But we have the gallbladder here that's thickened, pericolous cystic fluid, and if you zoom in, you can absolutely see some intramural gas. And so we can kind of switch over to a different imaging modality, not necessarily a CT, but a little bit more in depth with a HIDA scan. And a HIDA scan is using a certain radioisotope that is absorbed through the liver, usually in normal functioning liver. And then eventually that isotope is released, and you can start to see the buildup within the gallbladder. If you don't see or you see abnormalities with the uptake of that radio tracer in the gallbladder, then it is likely indicative of cholecystitis. You can also map out some of the common bile duct, but it's not as good. So for cholecystitis specifically, it's actually pretty good at sensing disease. Now, here, a lot of times, you may have heard it a few times today, we typically use, or we kind of reference the Tokyo guidelines. Now, this has been a guideline that has been revised up to 3 times, with the most recent in 2018, but it's fairly good at kind of delineating how we think about diseases, how we make the diagnosis, and then also the severity of it. And so kind of what we were talking about as far as the presence of fever, systemic inflammation, and then as well as the imaging findings, regardless of the modality that you use. And so that's to make the diagnosis of cholecystitis and then figure out the severity. And really, I would really just point to the difference between mild acute cholecystitis and as well as severe cholecystitis. And that's typically when you have hematologic dysfunction, when the platelets start to shoot or to drop down, you have INR that's greater than 1.5, and then of course if a patient's needing pressors despite antibiotics. And so these Tokyo guidelines actually help us to determine, once you figure out which block of disease state they're in, you can kind of shift to figuring out the best way we can treat them. Now, I'm going to bring you down to the grade 3 or severe patient, because we're all going to start with antibiotics. And then whether or not they're responding to those antibiotics, whether there's ongoing systemic inflammation, then we can determine, hey, does this patient yield emergent surgery where they need to go right now? Or are they a poor surgical candidate and we need to figure out other methods of treatment? And so we come down into the very, very bottom or the middle of the screen. We have the presence of early or emergent gallbladder drainage, and that's where GI likes to come in. Well, there's always interventional radiology, but we also have some options within GI. And this is the brief summary of something that we are probably very familiar with, is the presence of these specific bacteria, E. coli, Enterobacter, Pseudomonas. And typically, we start with either dual therapy with the cephalosporin and metronidazole, and then you can also consider piptazo from also an inpatient standpoint. There are times when you're going to have an increased risk for resistance, and so you can consider carbapenems in these particular cases. And then really just to kind of hone on, I won't definitely go into this because I'm not a surgeon, but ultimately we recommend cholecystectomy, and simply because the likelihood of recurrent complications within 3 months if these patients do not undergo cholecystectomy within that admission. And so, those are going to be difficult patients that surgery is like, I don't feel like it's their best option. And so there are other options, including percutaneous draining from IR. And then on the top image, you can kind of have a percutaneous drain that goes into the gallbladder. And it's great for something that's alleviate kind of any obstruction in there, alleviate some of that pressure, and give a little bit of that source control. The problem comes that they're not very good at taking out the stones. You can't go in there with another, you're literally just draining the fluid that may be building up. And so we in GI have been able to, with this new advent of a lumen opposing metal stent on the bottom, it's kind of this dumbbell looking thing where we connect the stomach or even the small intestine to the gallbladder, and we can effectively drain any infection that can be in there. That lumen is pretty big, so we can actually go in and break apart the stones or pull it out, and then eventually use this as an alternative method to treatment of acute cholecystitis or even chronic cholecystitis in patients who are not a good surgical candidate. And so new evidence is starting to come out showing that there's an associated lower risk of adverse events, reinterventions, and of course readmission. So I think it's probably going to be one of those things that are coming up in the future. It's just unfortunate that not every provider can do this. This is more of a therapeutic or an advanced maneuver. And so we move into our favorite is choledocholithiasis. Now, again, this is fairly rare, compared to all stone disease. The real important piece here is to stress that 90% of all these common bile duct stones that we find also are coming from stones within the gallbladder. And so this is the key piece to say, hey, even if we treat the cholelithiasis or the choledocholithiasis, we still need to figure out a way to prevent it from coming back. And so that's why we recommend a cholecystectomy within the same, or at least a surgery consult to get a cholecystectomy at some point, because of the high risk of recurrence. And so something I want to really stress here is that the small stones within the common bile duct can actually pass spontaneously. Less than 5 millimeters is a little bit lower risk, and they can pass spontaneously. They can still have an increased risk of pancreatitis because they can transiently pass through that duct, and then eventually, they pass through the duct, but then there's still the sequelae of inflaming the pancreas. And so really, when we have choledocholithiasis, making the diagnosis with imaging or with labs, and really that slam dunk diagnosis is going to come from a person who has obvious cholangitis. They have an obvious stone in the common bile duct on any kind of imaging, despite being on a right upper quadrant ultrasound. But really the two things I want to bring up is the total bilirubin greater than 4. If it's greater than 4, then it's like, oh wow, this is a high likelihood that there's a stone in the common bile duct or some kind of obstruction. And you have the presence of CBD dilation, and typically we go greater than 6 millimeters in the setting of a native, or so if they still have the gallbladder. And so those are two things. Now, unfortunately, it's not perfect. We definitely have a few people that come in. Oh, I'm sorry. Imaging, just to clarify this point, that right upper quadrant ultrasound is not very specific or sensitive, especially if you're looking at that common bile duct, because of how deep it is. It really is user dependent, and it's really up to 50% sensitive. CT is the same thing, where you can maybe see a small stone. But the other test that we really look for is MRCP or EUS. And EUS is the endoscopic ultrasound. Now, that they have to undergo a procedure, they have to go sedation. And so that is probably it's still a good test, but it may not be your first thing that you reach towards. And so MRCP is absolutely a great thing. It may not be the best for something that's very, very small, like less than 6 millimeters, and those stones that could potentially pass, but it's a good test. Now, I want to make this point about an ERCP. So that's us going in with the side viewing scope. Now, it is technically the gold standard for diagnosis of choledocholithiasis, but the problem comes that we don't typically use ERCP for diagnostic purposes. We go in there for therapeutic purposes. And so typically using an MRCP and an EUS is probably a little better. Now, a lot of patients, don't come in with these slam dunk diagnostic features, and so we have to evaluate with an EUS or MRCP, and this is just demonstrating that we have two different aspects, two different tests that are very, very specific and sensitive at 93% and 96% respectively. Now, surgeons can also do an IOC or intraoperative cholangiogram either before or after we do an ERCP, and they can essentially shoot dye down into the common bile duct and evaluate whether or not there's an ongoing obstruction. And so these are up the top, those imaging, it's an ultrasound and then a CT, and then of course our tried and true MRCP with a filling defect with the arrow sign. And so choledocholithiasis is not an emergency by itself. Now, There are, again, we talked about having an ERCP before or after the surgeons do a cholecystectomy, and that's absolutely reasonable. It's not like we have to do it first, despite what, depending on how the patient presents. And then really, I want to talk about the idea of in a patient who's just presenting with choledocholithiasis, that we don't need to jump in and do an ERCP right away. There are several different research that has kind of gone into whether or not we can just wait and see how they present. It's absolutely reasonable to say, hey, this can potentially even be done as an outpatient, but ultimately, this is not an emergency. It is not an urgency either. Now, there are times when the persistence of that choledocholithiasis can lead to cholangitis, and in those patients, they can, of course, come with a higher mortality rate, up to 30%. Now, this is something that we've all probably learned at some point, a Charcot's triad, the presence of abdominal pain, fever, and jaundice, as well as the presence of shock and altered mental status. And that really comes from, the diagnostic criteria of cholangitis. And this is on the chart on your left, we have the presence of the Tokyo guidelines for cholangitis. And really, it just goes upon those particular things, whether jaundice. In the Tokyo guidelines, they kind of look at the presence of a bilirubin greater than 2, but we kind of talked about the bilirubin greater than 4. So it really depends on what you're citing, but typically anywhere from 2 to 4 is probably, it's reasonable to say that you have a concern for jaundice. And so really, the Tokyo guidelines is something that we often use to determine severity. And this is very, very similar to the presence of acute cholecystitis and determining their severity. And so it's whether it's INR greater than 1.5, the decreasing platelets of less than 100,000, and then even, of course, the presence of levofed or using vasopressors to keep their blood pressure up. And really, the treatment for this is going to be antibiotics. Your first line therapy is going to be antibiotics, and it's very similar to cholecystitis, whereas you're going to have a third-generation cephalosporin with metronidazole, and you can also consider carbapenems and fluoroquinolone and metronidazole. Now, our guidelines, at least, have been suggestive of, or suggest that after we do something about cholangitis, or we do go in there and we drain it, whether it's IR or we do an ERCP, that we recommend continuing antibiotics for at least 4 to 7 days. Now, if you look into the current literature, actually just a few months ago, there are some evidence to say that, hey, we can consider shortening that antibiotic dose time frame to 4 days after we perform some kind of intervention. And so, really, this is probably the sticking point of my presentation, is that even in cholangitis or ascending cholangitis, that this can be considered we can consider an urgent ERCP if they're not improving on current therapy, like with antibiotics and supportive therapy. ERCP within 48 hours. Now, the alternative, depending on your institution, you can also consider a placement of a percutaneous strain, but placement of a percutaneous strain is not definitive, and you would still need to do an ERCP at some point. And you're technically you can be giving them patients more risk for infection or complications from that procedure itself. And so I think it's reasonable in certain patients to consider ERCP urgently. Now, you can consider an elective ERCP at some time during the hospitalization if they're improving with antibiotics. And so that's not necessarily a rush to get in there and do something. Now, of course, there's always these caveats. If a patient's not responding, if they're on pressors, despite you giving the high doses of antibiotics, then you can consider or you may recommend doing an ERCP within 24 hours. But I would really stress the point of 48 hours or so is our decision time to make to do an ERCP. And so this is a little diagram of our ERCP, and we take on the left side, we have a fluoroscopic image of us taking a side viewing scope, going up into the common bile duct, and then taking a balloon and sweeping it out after we've done a sphincterotomy. So we open up that area to alleviate any increased pressure, and then we essentially just taking stones and then sweeping it all out. It can be simple, but getting there is the hard part. And so other alternative options do include the surgical options. Now, this is probably decreasing in frequency given the expertise or local expertise of ERCP, but there are options. I think some of these procedures definitely have a similar adverse event rate, but some of these procedures also require a repeat ERCP. And so that's where the caveat comes in. And so we'll move on. I know we've talked a lot about other stone disease, but we'll move on to gallstone pancreatitis. And so this is something that Dr. Eagle touched about before. And so these can be very, very severe. I mean, they're coming in and they're acute, they're tachycardic, they're in pain, a 10 out of 10 pain, the worst in their life. But the idea here is like, what can we do to treat besides aggressive hydration and pain control, and is this thought process of using or doing an ERCP to alleviate these stones. Now, really the big point that I want to make here is that in the absence of any true obstruction or cholangitis, then it's probably best to avoid rushing in to do an ERCP. And this is because of the, based off the thoughts of the single hit hypothesis, is that if there's a stone in there, and usually smaller stones are more likely to create these complications with acute pancreatitis, they eventually pass, and then the inflammation subsides on its own. Now, if we go in to do an ERCP, there is a high likelihood of us getting into the pancreatic duct and worsening their situation. And so we typically we kind of balance that risk of the procedure versus the risk of the complications of acute pancreatitis. And so typically we reserve doing an ERCP urgently in the setting of no cholangitis or no clear obstruction with a rising bilirubin. This is just a little quick chart of what we talked about, mainly just whether or not there's presence of symptoms and how they're doing after initial antibiotic regimen. And so really I want to stress here that's 48 hours in the presence of any systemic features. Now, here we are talking about ERCP. We love to do it, but there are times when, even when we're treating cholecystitis with a cholecystectomy, or if we're doing an ERCP, there are absolutely risks. And so sometimes you may see complications including biliary leaks. And so this is according to the Strasbourg classification. And really all I want to stress here is assistance in helping to figure out where this leak is, because we really need to know whether or not it communicates with the common bile duct. If it doesn't involve the common bile duct, or if it's a complete transection, we in GI are, we're not as helpful, unfortunately. And so really the treatment is focused on this idea of pressure gradients. We decide that a leak is a high-grade leak or a low-grade leak, depending on when we get in there and we can fill that common bile duct, whether or not everything fills, or if we already see a leak right away without the whole biliary system filling. And so what we do to kind of mediate this pressure gradient is essentially doing the same thing that we do for stone. We create a sphincterotomy, we cut the papilla, and then we place a stent there. And it's not necessarily a stent to cover where the leak is at, but it's really to help the bile that's forming from the patient and drain appropriately, because we wouldn't want it to go out into the abdomen and causing them to have peritonitis or increasing JP drainage. And so this is ultimately another avenue for the bile to drain to. And so that's the thought process. It's been very, very successful, I think, in most cases. And usually we leave the stent in there for about 4 to 6 weeks and allow that leak to heal on its own. And then eventually, we can go with IR or surgery can pull their JP drain at some point during that treatment. But this is something that we can do in conjunction with our surgical colleagues. And then to round these out, we do unfortunately have perforations. We classify our perforations depending on what is injured, and so helping to kind of figure out. Usually we can see it. Unfortunately we can see it when we're doing the ERCP, but there are times that patients just have persistent abdominal pain and they just don't look clinically well. And so getting an MRCP or generally a CT, contrasted CT, can help to determine where these injuries are. And so we determine injuries based on where they're at. Type 1 is typically when we push in the scope and we can perforate that bowel wall. Type 2 is when we make too much of a cut on the sphincterotomy. And then type 3 is when we use the wire and it kind of gets up in there and irritates, because any injury with the common bile duct. Type 4 is like just retroperitoneal air. While we do expect pneumobilia, meaning air within the common bile duct, we don't typically expect to have any retroperitoneal air. So that definitely is a type of concern for perforation. And so most times we can consider treatment with endoscopically, but specifically in large duodenal wall perforations, unfortunately, we would have to consult surgery to assist. And so to kind of round this all out, I really wanted to stress the idea of recognizing the problem and its location, because the location and its symptoms will help us determine that treatment. As we can see, like recognizing what is cholelithiasis or choledocholithiasis as the cause is really important. And then next to that is the timing of our interventions. We give adequate antibiotics in about 48 hours or so. That's when we can make the decision point of saying, hey, we need to go in to do an urgent ERCP. Now, and then we also talked about the pancreatitis. Even though these patients are literally like 10 out of 10 pain in your care, we're not necessarily at an increased risk to, we're not necessarily rushing to do an ERCP with gallstone pancreatitis, and that's really because we don't want to exacerbate the problem. And then number 4, I would probably advocate for the institutions that can perform it, that in the event that there's a poor surgical candidate and they may not want a percutaneous drain, they don't want something, our patients don't want something sticking out, that GI may have an option for you if we do therapeutic EUS, and we can place a stent into that gallbladder or into the common bile duct to alleviate any kind of infection or obstruction and use that as an alternative modality. Now, it's not currently prime time right now, but I think there are certain institutions that are definitely more open to performing these procedures. And with that said, I'd like to thank you for your time, and look forward to meeting you.